Okay, so continuing on with our snow day, we have epistaxis as one of our first upper respiratory disorders. This is a common problem. It can be caused by little kids picking their nose. It can be caused by drug use, especially those that inhale or snort it. We can see it with hypertension, can cause bleeding. We can see oh, I lost my train of thought again. The occurrence, especially with little kids, we're going to see an anterior bleed. With adults, we may see an anterior or a posterior bleed. The assessment, the nurse is going to document how much, what happened with the occurrence, how much blood is it? Is it bright red blood? Is it dark red blood? If it's anterior or if it's posterior, any pain associated with it. Oh, I know the other cause can be trauma. You know, especially if gentlemen are fighting and somebody hits another in the nose. So we're going to document it. Interventions, nursing is good. For nursing, typically what we do is we have our patient remain quiet. We have them pinch the bridge of their nose, leaning forward, for about 10 to 15 minutes. You can use ice on the back of the neck. It can be helpful for a posterior bleed. You can take a little rolled up gauze and stick it between the lip and the gum, and this can help with an anterior bleed. Medically, they may need to cauterize it either using silver nitrate sticks or they can use an electric cautery. They may want to use packing. Packing is for an anterior bleed, and this is where they put a tampon-like device up into the nose, and it will provide pressure in order to cause to stop the bleeding. If it's a posterior bleed, your patient's going to need an inflatable balloon, and the next slide shows an inflatable balloon, and which you can see it's inserted. The patient's going to have this wire or string coming out of their mouth, and it's going to be inflated to provide pressure. Now, one of the problems with either having a packing or a inflatable balloon is it can cause some hypoventilation. So we're going to need, for nursing interventions, we're going to need to monitor the pulse ox. We're also going to be assessing for respiratory distress. Whenever we take a deep breath, or we take any breath, about 45% of the oxygen that we inspire comes from our nose or our nasal pharynx, and the rest can come from the mouth area. So we want to assess for any respiratory distress. I will tell you that an inflated balloon is very painful, so you're going to want to be assessing for pain. We're going to want to do oral care because now our patient is a mouth breather. And so they're going to be breathing in and out, and we don't have the luxury of having hydration or having humidity. So they're going to need oral care. A lot of times what you'll see is your patient will actually have like a little face tent, and it provides a lot of humidity to keep those mucous membranes moist. When they're discharged, we're going to need to talk to them about saline irrigations. We want to keep that nice and moist so that we don't have a rebleed, and it will help with crusting. We also want to teach our patients to avoid the use of NSAIDs, any aspirin, any Aleve, or any ibuprofen, because that will increase the risk of bleeding. We also want to avoid any strenuous activities, especially patients who do a lot of lifting, because this increases our interthoracic pressure, which will increase our nasal pharynx pressure, which can cause a rebleed. Next, we're going to talk about rhinitis. We have allergic rhinitis. Allergic rhinitis is a result of an antigen, and our body becomes, our body, the little white cells and the little mast cells will flock to the area where the antigen is, and we have the release of IgG and IgE, which causes a rush of blood to that site, and the little mast cells release histamine, which causes congestion of the nasal blood vessels. And what we'll see, our manifestations, is going to be either a stuffy nose or a runny nose. So what we're going to do for that is we're going to management as avoidance therapy. And you see this a lot with patients. They'll talk about that they were allergic to ragweed when they were in the Midwest. They moved to Arizona to avoid ragweed season, which is typically all summer long. But then they develop new allergies when they're here, and they'll say, well, now I'm allergic to the date palm. Well, it's not really the same allergy. It's a different allergy. We can use drug therapy. We use antihistamines. One of the problems with our antihistamines, as you remember from first semester, is drowsiness. We do have a lovely set of new antihistamines that don't cause as much drowsiness. We can also, if we have stuffy noses because of the nasal congestion, we can use decongestants. Some alternate therapies, we can use aromatherapy, which is substituting one antigen for the smell of another. Studies have shown that this isn't really working, but we do have that. We also have a desensitization therapy. Our patients that have allergic rhinitis, they can get tested to see what is their allergy. And through there, then they can be desensitized by getting little bits of the allergen each and every week. And the theory is that our antigen antibody reaction is going to be decreased. Now, viral rhinitis, this is a common cold. And when I was doing some research, I noticed that there are over 250 viral rhinitis viruses. And so when we look at it, it's kind of the same thing. It can be an allergic reaction, or it can be that the little viruses get into our cells, reproduce, and thereby causing more. With viral rhinitis, again, drug therapy is going to be really important. Our antihistamines, our decongestants. And for these, aromatherapy and desensitization won't work. Another one of our upper respiratory disorders is influenza. And if you all remember, back in 2009, we had the H1N1, or the swine flu. And everybody was all excited about it. The CDC put out lots and lots of information about the swine flu epidemic. When we look at symptoms, you'll see that you have on canvas, you'll see, is it the cold or is it the flu? With influenza, we're going to see pain, muscle joints, fatigue, and I'm not talking a little bit of sleepiness, I'm talking downright, I can't get out of bed fatigue. We're going to see a temperature. Are they going to have sneezing? Probably not. Management is going to be with antivirals. If it's caught within the first 24 to 48 hours, antivirals have shown to decrease the incidence of influenza by about the length and the incidence about 25 to 30%. The other thing that will help with influenza is getting your flu vaccine. And yes, I get my flu vaccine every year. Doesn't matter. And the flu vaccine is based on what the CDC and the powers that be think is going to be the most prevalent influenza virus for the flu season. So by getting your flu vaccine, you can decrease the incidence of influenza. Now you say, well, who can get the influenza vaccine? You want to look in your book at versus the attenuated or the dead virus versus the live virus. The attenuated or dead virus can be given to anybody from 6 months of age all the way up to 90-something. The live vaccine, you want to be cautious with those patients who are immunocompromised, because basically what we do is we give a live vaccine and then the body makes the antibodies to it. So you want to use the dead one for patients that are immunocompromised, that patients that are on chemotherapy, patients that are on corticosteroids. If you do happen to get the influenza virus, supportive measures only. Lots of fluids. You can use gargles for those sore throats, antihistamines for the runny nose, antipyretics, and yes, I know it's misspelled, for the fever, and bed rest. The next problem we're going to cover really quickly is sinusitis. And what is sinusitis? It's an infection of the sinuses. If you remember, we have 5 of them. They're on the face and up into the forehead. It can be caused by a virus. It can be caused by a bacteria. It can be caused by rhino. The causes are multitudinal. Complications of sinusitis, one of the big ones, and you'll notice on your pretest this was there, is meningitis. If you think about it, we have these sinuses that are in the behind our eyes, and it's just a capillary membrane away from our brain. So when we look at patients that have sinusitis, and I did have a patient that this happened to, he came in with sinusitis from snorting cocaine, and he left the hospital in a persistent vegetative state because he developed meningitis from this. So we want to look at, does our patient have a headache? Yes, that's normal for sinusitis. Do they have a stiff neck? Do they have a fever? We're going to be looking at that especially if they have sinusitis. The symptoms for sinusitis are similar to allergic rhinitis and for influenza. Patient complains of a headache. They may have a fever. If it's bacterial, they may have some really colorful nasal drainage. If it's because of allergens, it should be clear. Management, we again want to avoid those allergens. We want to use our drug therapy. Our patients can have surgery, especially if this is a chronic sinusitis. They'll do an antral irrigation where they actually go up into the nose and they find the sinus opening that they need to, and they will actually instill and expel saline, because the stuff that gets in there gets really thick and it won't come out easily. We can do endoscopic surgery, again, where they go up through the nose, they find the sinus that they're looking for, and they actually can open up that opening to allow all of that drainage. Anytime we have surgery, of course, we have a risk for DVT, so we're going to have our stockings on. We're going to be monitoring them for pain. We're going to be monitoring their lung sounds, assessing for any rhonchi, which could be a pneumonia afterwards. This is also another problem that we can see with children: foreign bodies, obstruction of the nose, or we can have a polyp. And here's the polyp right here. Just a little growth that's inside the nasal passage. Polyps, they can be removed, again, using a endoscopic surgery. We're going to be watching for bleeding. Our patients are going to have nasal packing afterwards. A foreign body, little kids stick beans up their nose, pennies, whatever they find that they can stick up their nose. And these can be easily removed through the emergency room or through the doctor's office. If it's small enough, you can have them blow their nose and the foreign body will pop out. Sometimes they need to go in endoscopically to remove it. Another